Hi, welcome to NUR 1210, and we're going to be discussing Chapter 55, Chapter 56, 57, and 58. Chapter 55 is Assessment of the Gastrointestinal System. The objectives of this lecture is to assess patients for complications of diagnostic tests, prioritize post-test care for patients having endoscopic procedures, identify factors that place patients at risk for GI problems, teach pre-test and post-test care for diagnostic GI testing to patients and families, identify general psychological responses to GI health problems, briefly review the anatomy and physiology of the GI system, describe GI system changes that are associated with aging, perform a GI history using selected Gordon's functional health patterns, and perform focused physical assessments for patients with suspected or actual GI health problems. Explain the use of laboratory testing for a patient with a GI health problem. So, first of all, what we're going to do is we're going to do assessment of the GI system. And this assessment of the GI system is going to be brief because I do know that the majority of you guys had discussed and had went over this system, in your anatomy and physiology course. So just like bear with me on this, and we'll complete this as soon as possible. So the gastrointestinal system, um, as we can see, we got mouth and salivary, gallbladder, colon, pancreas, rectum. You got a basic idea of what type of things composes the GI system. Okay, overview of the gastrointestinal tract. The gastrointestinal tract um, is a hollow muscular tube surrounded by four tissue layers, mucosa, which are, mucosa, submucosa, muscularis, and serosa. Um, the general the mucosa, which is the innermost layer, includes the thin layer of smooth muscle and specialized exocrine gland cells. It is surrounded by the submucosa, which is made up of connective tissue, and then the submucosa layer is surrounded by um, muscularis, and the muscularis is composed of both circular and longitudinal smooth muscles which work to keep contents moving through the GI tract. The outermost layer, the serosa, is composed of connective tissue. The GI tract is divided into the mouth, the pharynx, the esophagus, the stomach, and small and large intestines. And each of those basically form their own, uh, I guess, function. So know about the function, which is secretion, digestion, absorption, motility, and elimination. Know what the oral cavity is consisted of, which includes the buccal mucosa, lips, tongue, hard palate, soft palate, teeth, and salivary glands. Okay. So, I mentioned to you earlier about what the components are, primarily of the GI tract, which is considered, and we talked about, we started on the last slide. I clipped back over to that. The oral cavity, which is a component. It includes the mucosa. I told you the buccal mucosa, lips, tongue, hard palate, soft palate, teeth, and salivary glands. Um, the buccal mucosa is the mucous membrane lining the inside of the mouth. The tongue is involved in speech, taste, and mastication. mastication, which is another word, mastication of chewing. Small projections called papillae cover the tongue and provide a roughened surface, permitting the movement of food in the mouth during chewing. The hard palate and the soft palate together form the roof of the mouth. Teeth function to prepare food for the digestion of by cutting, tearing, crushing, or grinding the food. And swallowing begins after food is taken into the mouth and chewed. Saliva is secreted in response to the presence of food in the mouth and begins to soften the food. Saliva contains mucin, an enzyme called salivary amylase, also known as I think it's oh my gosh, ptyalin, which begins the breakdown of carbohydrates. The next cavity is the esophagus, and it's a muscular canal, and it extends from the pharynx to the stomach. It extends from the esophagus, extends from the pharynx to the stomach, um, or throat, and passes through the center of the diaphragm. Its primary function is to move food and fluids from the pharynx to the stomach. At the upper end of the esophagus is a sphincter referred to as the upper esophageal sphincter. When at rest, the upper esophageal sphincter is closed to prevent air into the esophagus during respiration. The portion of the esophagus just above the gastroesophageal junction is referred to the lower esophageal sphincter, or LES. So the upper esophageal sphincter, sometimes they'll abbreviate and call it the UES, and then the lower esophageal sphincter, they would call that the LES. When at rest, the LES is normally closed to prevent reflux of gastric contents into the esophagus. If the LES does not work properly, gastroesophageal reflux disease, or GERD, I know you guys have heard of that before, GERD, can develop. The next part of the gastrointestinal tract, the components that I named earlier, would be the stomach. The stomach is located in the midline and left upper quadrant of the abdomen and has four anatomic regions: the cardia, fundus, body, or corpus, and antrum. Smooth muscle cells that line the stomach are responsible for gastric motility. After ingestion of food, the stomach functions as a food reservoir, or place, for you to store your food. That's another word for reservoir, where the digestive process begins using mechanical movements and chemical secretions. The stomach mixes or churns the food, breaking apart the large food molecules and mixing them with gastric secretions to form chyme, uh, which then empties into the duodenum, part of the intestines, and then it goes into what they call the intestinal phase. And so the chyme passes from the stomach into the duodenum, causing distension, and it assists by secreting like hormones that inhibits further acid production and decreases gastric motility. Okay, the next section of the GI tract uh, um, would be like the pancreas. Um, I'm sorry. No, I'm sorry. The next part would be when we're talking about GI would be the pancreas. Um, the purpose of the pancreas is basically um, kind of like more like a exocrine type feature, and what it does is it secretes enzymes needed for digestion of carbs, fats, and proteins. um, the portion that contributes to that is the islets of Langerhans, alpha cells producing glucagon, and beta cells producing insulin. So, if you could just, we're not going to go like a whole lot into that now because you'll get a lot of that when we discuss endocrine. But I'm just giving you like a basic anatomy on the function and what the pancreas look like and what their main goal is. Also, as far as the anatomy, when we're talking about the GI system, you want to include the liver and you want to as well include the gallbladder, and the small intestine and also the large intestine. And if the largest organ in the body, um, and it's located, I'm sorry, in the right upper quadrant of the abdomen. Um, that is the liver. It performs 400 functions in the body, and that's quite a few functions. Um, um, it detoxifies and harmful compounds and stuff in the body, and it breaks down amino acids, um, which are proteins before they develop into proteins. So you can see why the liver is like very plays a big role. Also, let me see what else does the liver do. It works. It produces. Um, it works to help produce your clotting mechanism. It has a lot of functions. So I just want you to, but I really, the main thing I do want you to remember as far as the liver is how it detoxifies. Because that's the reason why a lot of times you guys, when a person has a poorly functioning liver, um, it's not breaking down the toxins and stuff in their body like it should. Also, then you have this section right here, which is the gallbladder. And the only real problem with the function of the gallbladder is that it collects, concentrates, and basically it stores the bile. So that's why it's kind of like a storage for the bile before it really gets to the intestines. So basically, that's the reason why a person can lose their gallbladder, and it's not like a real big deal. But you a lot of times will see people they'll suffer from what they call dumping syndrome initially before, like when they first get a gallbladder removed, um, and after a while it says, like I've read up on it, and it's they discussed about how you kind of almost uh kind of form or make another little pouch on your own. The reason why, after a while, initially you'll have that dumping syndrome, and then after a while it'll go away. Also, the small intestine and has three main functions, and the three main functions of the small intestine is movement, digestion, and absorption. The large intestine serves in movement, absorption, and elimination. Okay. um so right here is basically um gallbladder physiology, and you can look at it right there where I showed you, but I talked about that. And another picture of the small intestine if you want to look at it. And right there, I highlight once again the three main functions, which is movement, digestion, and absorption. Large intestine, three main, you got to know the portions, you guys. You got like the ascending, the transverse, and the descending colon. And you got the sigmoid colon and the rectum. All of that is part of what they consider the large intestine. Okay? So I just want you guys to be aware of that, and also the three main functions of the large intestine was the movement, absorption, and elimination. Okay, now we're going to start discussing about assessment techniques of the GI system. Of course, you guys, you know you're going to get a history. You're going to get a nutritional history to begin. Um, like, for instance, if a person has changes in the taste of their food, if they have dysphagia, nausea, and vomiting, dyspepsia, any type of potential food allergies, you're going to discuss that. And those are the type of questions that you're going to ask from the patients. Also, you want to discuss family history or um, any type of genetic risk. So I mean, based on that, a lot of times people may tend to have their own familiar history or be more prone to have some type of disease process related to genetics. Just like, for instance, a lot of times if a person may have had somebody in their family that had like a colon cancer or had polyps, a lot of times you'll see that. And a lot of times, with, like, for instance, colon cancer is like the most treatable disease type of cancer. And so, like, if you're doing a history and you learning this, then you know that that's something that you're going to look at. That's something you're going to do a colonoscopy on the person or whatever. Okay. So, next, you have the gastrointestinal system, which is what you want to assess on is what you want to assess. So after you ask all your questions about their habits, about their familial history, you're going to do uh, a gastrointestinal system assessment, and you're going to do this physical. And so, what this involves, it's a pretty comprehensive examination of the patient's nutritional status, mouth, and abdomen. So, in order for you to prepare a patient for examination of the abdomen, always make sure um, that the patient has like an empty bladder, and then make sure that they lie in a supine position and that they have their knees bent if it's possible, keeping the arms at the sides so that when you're looking at them, they won't get tense or whatever, and tense up their like abdominal muscles. And usually it begins at the patient's right side and it proceeds in a systematic fashion. So, what you're going to do is you're going to start at the right upper quadrant, the left upper quadrant, the left lower quadrant, and then go back to the right lower quadrant. If areas of pain or discomfort are noted from the history, the area is examined last in the examination sequence. So, listen to what I'm telling you, because I know I have seen questions in the past where they have asked, like, if when you get in the history, if a person's telling you, oh, my left lower quadrant or my is hurting, or my right lower quadrant, what they're basically saying is you got to make sure that even though I gave you the systematic fashion that you're supposed to do the exam, that you always palpate that area last when you're asking them, are they in pain. If appendicitis or like an aneurysm is suspected or something like that, then you, of course, you know that you're not going to do any type of palpation. Okay, so then you're going to do inspection. So you're going to inspect for skin for any type of symmetry, discoloration, distension, bulging, or that type of thing like that. Um, you're going to watch for the presence of ecchymosis around the umbilicus. As we talked about skin, y'all know what ecchymosis is. Ecchymosis looks like little red little marks, And if it's around the umbilicus, that could mean that a person might have intra-abdominal bleeding. Another name for that is called Cullen's sign. It's spelled Cullen apostrophe S sign. Cullen's sign. So that's what that means. It's an indication of intra-abdominal bleeding. Finally, you want to observe the patient's abdominal movements, include the if they're having like any type of normal rising and falling with inspiration and expiration, and note any distress when they're moving. Your peristaltic movements are rarely seen unless the patient is thin and has increased peristalsis. If these movements are observed, note the quadrant or origin of the peristaltic flow. Report this finding to the healthcare provider because it may indicate that the person possibly could have some type of intestinal, like obstruction, or something like that. The next type, after you do your inspection, you're going to do an auscultation, and you're going to make sure that when you're doing it, you're going to listen to all four quadrants. So, how do you do the auscultation? You place the stethoscope lightly on the abdominal wall while listening for bowel sounds in all four quadrants. And you're going to begin, once again, you're going to begin this time at the right lower quadrant. The bowel sounds are created as air and fluid move through the GI tract, so they are normally heard as relatively high pitched. They sound like irregular gurgles, and every 5 to 15 seconds or so, with a normal frequency range of 5 to 30 per minute. Bowel sounds are characterized as normal and hypoactive or hyperactive. It doesn't really matter. They are diminished or absent after abdominal surgery, and we already know this because we discussed this when y'all were talking about. We was discussing how everything slows down because of the anesthesia post surgery. Or if you have a patient who has like a peritonitis, which is an inflammation, or a paralytic ileus, of course you're going to have decreased bowel sounds. You're going to have increased bowel sounds, especially loud gurgling sounds, related to increased motility of the bowel. Um, these sounds are usually heard in the patient that has, like, for instance, if they have like uh, diarrhea, or if they have like a gastroenteritis or something going on, and if they have like what they call a complete uh, intestinal obstruction. And barbo barborygmus is what they call. Let me spell it. Borborygmus, and that is like when you have real increased bowel sounds. Um, Percussion is when you detect masses, fluids, airs, and you're trying to assess like the size of the organ. Like for instance, if a person has an enlarged liver or spleen, which, like for instance, another word for enlarged liver is hepatomegaly, and splenomegaly. And remember, you guys, I've talked to a lot of y'all about y'all medical terminology, and the fact that you know that megaly means that something is enlarged. So keep working on that. So, like for instance, when a person percusses, um, which the liver and spleen can be percussed, um, you'll hear dullness when you're percussing. And the only way for you to really be able to detect or know the difference is to percuss other areas of the abdomen, and you'll be able to hear the difference in the way that it sounds, or the dullness. Okay. And then last is basically the palpation that you would use when you're assessing. And so and you're just assessing it once again for massness or tenderness. And then also um, uh, for the Bloomberg sign, which I know a lot of y'all remember from when you was doing your physical assessment, and that's like what they call rebound tenderness. So like when you press down, and as their abdomen is going back up, it hurts really bad right then. So when you also palpate, you guys, make sure you do. Well, they do have two types. They have the light and they have the deep. So light is considered like a half to 1 inch, um, and anything past that would be like deep. And you only have to do light palpation if a person has a really, really big mass, because then you will be able to detect it. And anyway, as far as the psychosocial, so when doing the physical assessment, let me see, you're going to inspect, you're going to auscultate, you're going to percuss, and you're going to palpate. And I told you what all these consist of, and I want you to remember like the things that I told you when you're performing each one of these, like inspection and about the culling sound sign. Remember when I was telling you about the ecchymosis around the umbilicus and that kind of thing. So I want you to remember when you start palpation and how you go about it. And then I just want you to keep it just like that. I just want you to remember the things that I'm emphasizing as we're doing this. Um, so when you're assessing the gastrointestinal system, and you're performing a psychosocial assessment, emotional, you're gonna see like if there's any type of emotional stress that may be associated um, with the development or exacerbation, which is like a flare up of the irritable bowel syndrome or any other GI disorders. If the patient is diagnosed with cancer, he or she is expected to experience the phases of the grieving process. And I want you to realize that it's like very common for a person to go through like the depression, anger, and the denial. Okay, so what you're going to do is uh, they do have certain tests and stuff that they run for individuals, like blood tests um, that's associated with a person having some type of abdominal um, ailment or problem or even disease process. So we're going to get like a complete blood count. You're going to get clotting factors. You're going to get electrolytes. Um, and then you're going to get assays for liver enzymes, amylase, bilirubin, ammonia, and those type of things. Complete blood counts. Remember, you guys, we discussed that. That's the one with the purple tube, and clotting factors is the blue tube. And what this is like really, really, first of all, when you think in terms of a complete blood count, what you're going to be trying to assess for, you guys, is whether or not somebody might be bleeding out. So they may be anemic or something like that, and that's like very important. Clotting factors. Remember how I was telling you guys that one of the functions of the liver is clotting, you know. So you want to see if a person has that ability. Electrolyte panels, and then you're going to do liver enzymes, amylase, lipase, bilirubin, which is the primary pigment that's in the bile, and serum ammonia is, or they detoxifying their body like they should. So that's the reason behind them ordering, these particular types of blood tests to see if there's any abnormalities. Also, they can order like CA 19-9 or CA, like if they're trying, which what they consider oncofetal antigens, which basically they test, for cancer. Um, you're gonna test the urine to see if there's any urine urobilinogen. Oh, okay, so to make sure that they don't have any bile or whatever, or amylase or increase, um, where they're not breaking down anything. You're gonna do a fecal occult blood test, anything like that. You're gonna test to see, maybe if a person has steatorrhea. Steatorrhea is, if they got like fat in their blood, any oviparasites, and of course, Clostridium difficile, which is like C. diff, and you're going to test for those type of thing. And then you're going to do various radiographic imaging on people. um, you can do upper GI series, which consists of just like a series of x-rays. You can do the barium enema, um, and you could do just they have all types of GI radiographic tests, that a person can do to assess for any types of problems. Okay, so what I wanted you to know as a nurse, what type of things you would do, um, just being a nurse prior to various types of testing, upper GI series, for instance, and small bowel series. You'll see them order that in the hospitals. And before the test, the person, you want to make sure that they're NPO for at least 8 hours. You're going to withhold any type of pain medicines, any type of anticholinergics. And anticholinergics, of course, you guys, would decrease intestinal motility uh, for at least 24 hours. And the patient is to drink 16 ounces of barium, and they're going to rotate them like on the examination table. Um, After you do that, and you want to get rid of the barium, they might give a person a laxative, and then they're gonna encourage them to drink as much fluid as possible, and usually a person has like white chalky stool for like about 2 to 3 days post exam. Okay, so then the next test is the barium enema, which enhances radiographic visualization of the large intestine. You only to drink clear liquids or given 12 to 24 hours before the test. They're NPO the night before. And then, of course, you're going to do the bowel cleansing process. After this test, of course, it's going to be the same thing. So, this is like the process of the barium enema. You're going to be given the barium liquid. It's instilled into the large intestine through the anus. They're going to have radiologic view of, right here, you guys. Y'all can see of the barium enema. Um, the next one is the percutaneous transhepatic cholangiography, and basically this test here, they're just looking for the a biliary duct system, like to do an X-ray in case there's something with the actual duct system. The prep for that is to have a laxative before the procedure, and the NPO for 12 hours before the test, and they're gonna do uh, a coagulation test, and they're gonna have an IV infusion, and they want you to be on bed rest or so for several hours after the procedure, and they're going to assess the vital signs. So basically, that's the type of things that you would tell a person post procedures for those specific procedures. And a lot of times on your test, they'll ask you to make sure that you're aware of the various procedures. Okay. Also, okay, next, you guys, when I was talking about the percutaneous transhepatic cholangiography, I really don't want you to too much pay much attention because they rarely do that now, so we could just move on. Also, the other test is the computed tomography, which is the CT, endoscopy, where basically they directly visualize the GI tract by a flexible endoscope. And what they do with the endoscopy is they evaluate for, like, because they're going in with a scope looking whether or not a person is bleeding, they have some type of ulceration or inflammation, tumors, cancer, or that type of thing. Um, and then they have the EGD. It's the same. But the difference is the EGD. They visualize the esophagus, stomach, and duodenum. And then your NPO for 6 to 8 hours before the procedure. You avoid anticoagulants, aspirin, NSAIDs. They're usually under conscious sedation. After the test, they they assess the vital signs every 30 minutes. Their NPO until gag reflex returns, and they have throat discomfort possible for several days because they're going down their throat. And priority to care is to prevent aspiration, and you monitor for signs of like perforation when they went down there. So I just basically want you guys to just know about the procedure. Um, so that you would know what type of things to monitor. Um, then they have the endoscopic retrograde cholangiopancreatography, which basically they're going in looking at the gallbladder, pancreas, and bile duct. It's the same thing. They got IV sedation. Their NPO 6 to 8 hours before the test, and with all these exams, if you're going down somebody's throat, which they do, and looking, um, they want you to make sure that you monitor the gag reflex and make sure that it returns prior to you offering somebody any food. You're going to assess for pain. And sometimes people often complain and say they might feel a little colicky afterwards. Um, then they have what they call the small bowel capsule enteroscopy, which they basically, I've heard of these where they visualization of the small intestine, and they have the little camera or whatever, and you take the little pill, and you only need water for 8 to 10 hours before the test. So that's all that you could take is the water, and their NPO for the first 2 hours of the testing, and application of a belt with sensors, and the capsule is usually taken with glass of water, and diet resumed 4 hours after taking capsule. And then usually the capsule, you just basically excrete that naturally. when you go use the toilet. And then what everybody knows about is the colonoscopy. The colonoscopy is considered an endoscopic examination, and usually you're looking at the large bowel, um, which is the colon and everything, and the transverse. And I told you about those when we reviewed anatomy. And they're usually given after 50 years of age. The person gets a liquid diet for 12 to 24 hours before the procedure. Usually, they encourage you not to take anything with red dye or anything in it. Um, they'll put you on some type of bowel cleansing routine, so you'll spend that whole day prior to probably, in the toilet. Um, Assessment of the vital signs every 15 minutes post colonoscopy. When they go in and look at your colon, they usually go in like right, I'm sorry, through your rectum, um, and they usually put you to sleep doing when they're doing with the IV so that you could be slightly sedated. And sometimes when they go in and they look, it might be a chance that they may have to do a polypectomy or a tissue biopsy based on what they see. But they generally they clip it off and doing the procedure, and you don't know the better. And then they usually send the specimen out so that it can be biopsied afterwards. But this is the most preventable type of cancer, is the colon cancer. So that's why it's so important for individuals to do it. um, and if they generally, if you don't have a strong history or whatever, they want you to come back only every 10 years. But if they have to take a polyp off or something like that, then they come and they have you come after 5 years. Okay, all right. Okay. Next is the proctosigmoidoscopy, the endoscopic examination of the rectum and sigmoid colon using a flexible scope. Um, they usually do a liquid diet, maybe 24 hours before the procedure. Of course, you have to do a cleansing enema or laxative. You position the patient on the left side in the knee chest posture, and usually they when they looking, a person usually may have a little air instilled into the rectum, so they might get a little gas pain. And if they when they go in, and they're looking at this particular section of the sigmoid, um, they would lay you on your left side. And if they do a biopsy, there might be just a tad bit of bleeding. So basically, a lot of these tests they name them based on whether or not, what part of the body or the GI tract they're trying to examine. And then, so this is a picture here of the procedure. Also, the gastric analysis, and that's basically the measurement of the hydrochloric acid and pepsin content for evaluation of aggressive gastric and duodenal disorders. Okay, and so they're NPO for 12 hours before the test, and then they do the nasogastric tube insertion, and gastric residual contents are aspirated and discarded. Um, Also, these type of disorders they mentioned in the text is Zollinger-Ellison syndrome. Um, and I just mentioned that name just in case so that you can recognize it if you were to see it. other tests um, is the ultrasound, and they like for you to drink 1 to 2 liters of fluid, and they would view. They're trying to view soft tissues, and then the endoscopic ultrasound, and that's useful in diagnosing tumors, lymph nodes, pancreas, stomach, rectum problems. Um, and then what they call the liver spleen scan, and that evaluates liver and spleen tumors or abscesses, organ size, location, and blood flow. Okay, now we're going to discuss Chapter 56, Care of the Patients with Oral Cavity Problems. The objectives of this chapter is to prioritize postoperative care for patients undergoing surgery for oral cancer, to promote nutrition, um, plan continuity of care, identify appropriate community resources, teach patients ways to prevent oral cancer, develop a teaching plan for patients who have stomatitis, develop a teaching plan for community-based patients, assess the patient's response to an oral cancer diagnosis, refer patients with oral cancer to appropriate support groups, assist the patient with oral cancer to identify coping mechanisms and support systems, plan care for patients who have disorders of the salivary glands, and use best practice for teaching or providing oral care for patients. Okay, the first disorder that we're going to discuss, you guys, will be stomatitis. Um, Stomatitis itis is a painful single or multiple ulcerations that appear as inflammation and erosion of the protective lining of the mouth, as you can see here. A lot of times you'll find people with stomatitis who have chronic kidney disease. They may have irritable bowel. Um, they have various types of stomatitis. They have non-infectious stomatitis, herpes simplex stomatitis, and traumatic, what they call traumatic ulcers. Okay, so secondary stomatitis is infectious stomatitis, and also it comes from drugs. So what you need to be able to distinguish is you need to be able to distinguish between the primary stomatitis, which is the most common type, is like a simple herpes simplex, and traumatic ulcers that people get from things like chemotherapy or that type of thing. And it generally results from infection by opportunistic viruses, fungi, or bacteria. And this is usually obtained when a person may, for instance, be immunocompromised. A common type of secondary stomatitis is caused by candida. So, like when you hear about people having some type of fungal infection, um, candida usually uh, is present in small amounts in older adults, or somebody who may have, for instance, been on antibiotic therapy, where, for instance, their normal flora or whatever have been killed. So this can also happen from a person having um, some type of chemotherapy, radiation, and or steroids. In addition, the mouth is more susceptible to secondary when or candidas when a person has HIV, or if they even have poor oral hygiene. Okay, so what you need to do as far as collaborative care, you need to do an assessment for this, and you're going to have ask whether or not they have a history of any type of recent infection, nutritional status, oral hygiene habits. You're going to see whether or not they have some type of oral trauma, which would be considered one of the primary types. Stress, drug history. You're going to look at any type of herbs. You're going to look at whether or not what their food selection is, whether or not they have certain types of foods which may trigger ulcers. You're also going to instruct them on avoiding hard, spicy, salty, or acidic food or fluids that can irritate ulcers. You're going to discuss with them about their oral hygiene, and you're going to encourage them to use soft bristle toothbrushes or disposable foam swabs, just like the kind that you see in the hospital, to stimulate the gums and clean the oral cavity as recommended. Um, you can frequently rinse the mouth with some type of um, regular solution, but not no like commercial mouthwash. And then the mouth care every 2 hours and twice during the night if a person has stomatitis. Next, oh, and then for that, also you want to talk about the oral drug therapy. Usually, people might have antibiotics such as tetracycline syrup and um, minocycline, which is a switch and swallow, as well as antifungals such as nystatin, which is also a swish and swallow. Um, IV acyclovir for people who are immunocompromised with herpes simplex. Then anti-inflammatory agents and immune modulators. Um, some of the symptomatic topical agents and you use as far as gargling and uh, you also use some type of mouthwash. Next, we're going to discuss leukoplakia. And leukoplakia is slowly developing changes in the oral mucous membranes, causing thickened, white, firmly attached patches that are slightly raised and sharply rounded. Most are benign. Most common oral lesion among adults is leukoplakia. Lesions on lips and tongues more likely to progress to cancer. May result from mechanical factors that cause long term oral mucous membrane irritation. Okay, and this is a picture of it, which is basically an early manifestation of sometimes even um, HIV disease as well. So and it can be found in patients with HIV infection, also patients who use tobacco products, um, um, uh, and also they said that when a person gets leukoplakia, they can't scrape the area off, like they do a lot of times with candidal infections. Um, Erythroplakia is what they call a red velvety mucosal lesion on the surface of the oral mucosa. It's a higher degree of malignant transformation in erythroplakia than in leukoplakia. So, a person who has erythroplakia tends to be more common to get some type of cancer transformation than people that have leukoplakia, and that's how that looks there. Okay, so erythro, you'll think about it as being a red, velvety looking, and it's more common for people to have that to for it to transform itself into some type of cancer. Okay, and a lot of times they tend to say that with erythroplakia, it's usually what they consider a precancerous presentation. Next, you have what they call squamous cell um, carcinoma. Squamous cell carcinoma is the most common oral malignancy, and it can be found on the tips I'm sorry, on the lips, tongue, and the buccal mucosa. Also, the oral pharynx. It consists of more than 90% of the oral cancers. So the squamous cell carcinoma is the most common form of oral cancer. It's a highly associated with aging, tobacco use, and alcohol ingestion. And as you can see right there, that's a picture of it. You have they have what they call mucosal erythroplasia, and remember that's like it getting big and inflamed is the earliest sign, and it mostly occurs on people who are greater than 40 years of age. And increased rate of oral cancer is found in people a lot of times that have occupations such as textile, plumbers, and coal and metal workers. Additional factors that contribute, such as sun exposure, poor nutritional habits, poor oral hygiene, and infection. The HPV 16 virus leads to that as well. Okay. The next type is basal cell carcinoma. Next to um, the squamous cell is the second most common type of oral cancer. Resulting lesions occur primarily on the lips. The lesion is asymptomatic and resembles a raised scab, evolves into an ulcer with a raised pearly border. Um, the lesion aggressively involves the skin of the face but does not metastasize. The major etiological factor for a person to get um, basal cell is the fact that they have exposure to sunlight. Um, then they have what they call Kaposi's sarcoma. Um, Kaposi sarcoma is a malignant lesion arising in blood vessels. Usually it's painless. Um, it's a raised purple nodule, or it's like usually it looks like a plaque, and it's found on the hard palate. It's found on the gums, on the tongues, or the tonsil. And usually when you hear people talk about Kaposi sarcoma, they are relating it to someone who it's associated with, like not HIV, but like people really truly having like what they consider full blown AIDS. Okay, and so as far as like assessment, when a person had or interventions when a person has a malignant oral tumor, you want to make sure that for the oral tumor, you want to have oral hygiene regimen, and whether or not a person even has use of dentures. You want to also assess, what that person's nutritional status is, um, and how all of that stuff is like affecting their quality of life. You want to know whether or not they're maintaining an open airway, semi-fowler or high fowler position you want to do for a person. You want to encourage liquids to liquefy secretion. Um, And like I said, you want to make sure they have an oral hygiene routine. You want to check Q2 hours if they have some type of surgery or anything for any ulcerative lesions and infections. And you also want to check, which is a sign of infection, is their platelet count. Malignant oral tumors intervention, and the first thing that of course they'll do is the biopsy. And they just doing the biopsy mainly because they want to make sure that they know for sure that it's a definitive, form of diagnosis. So they want to just make sure that they know for sure. And at times when a person has some type of oral tumor, if it's malignant, they'll do some type of radiation therapy, and they do that primarily so that they can reduce the size of the tumor. Then from there, depending on how everything is, they can reduce, and they can go to some form of chemotherapy. And then if it at all is any type of ability for them to do that, they can also do some type of surgical management and try to remove the lesion. But of course, that depends on how large the lesion is. And of course, like when they do depend on or want to remove it, and they're doing some oral to remove it, they're going to try to remove surrounding areas as well to make sure that they remove as much or all the tumor, if at all possible. Um, Prior to a person having any type of surgery, oral or anywise, you got to do your preoperative care. The person, the patient, and the family, of course, are going to receive some type of teaching plan. And you want to make sure that they understand the disease process and what they're getting ready to go through. You're going to teach possible expectations after surgery. um, when you and you got to remember, you guys, that we're discussing something as far as oral. um, so you're going to teach possible expectations after surgery. There may be expectations as far as placement of a trach, oxygen therapy, suctioning. There's going to be temporary loss of speech. You're gonna have an NPO status until, if, like for instance, let's say they have some type of sutures, intraoral sutures, and are healed. Um, you're gonna teach what type of post-op drug therapy and activity the person is going to have. Um, they may need to do some type of swallowing exercises, or work with a speech pathologist to assist with swallowing techniques. They're going to have thickened fluids, which may be needed to prevent some type of aspiration. Um, Generally, initially, when they get their pain medication, a lot of times they get IV morphine, um, and initially, and you gotta assess for respirations. Also, Tylox or Percocet is usually given as well. And like I said, when you mess with the oral cavity, you of course you're gonna check their breathing, and you're gonna check their gag um, reflexes. You're also gonna tell the family members that there may be a possibility that they may have some type of post-surgical drains, um, and then um, you're going to make sure that they have some type of community resource after surgery and when they get discharged, like some type of support group, or they're going to have some type of home care management of post surgery. So you're gonna maintain the patient's airway when they come from surgery, and that's the number one priority is to maintain the patient's airway. You're gonna protect the incision site to avoid infection. You're going to focus on pain relief and then nutritional status, knowing that the patient may be in PO for several days. They're going to participate in swallowing exercises. Um, you're going to start providing oral care very soon, an early post-op. They're going to elevate the head of the bed 30 degrees, and of course, like I said, you're going to refer them to community-based care. And those are the type of things that you're going to do, that you would do, that I'm telling you in order. Inflammation, acute of the salivary gland caused by infectious agents may result, or maybe if they have some type of radiation or immunologic disorder, um, they may have problems with the salivary glands. Decreased production um, of the saliva can lead also to um, sialadenitis, which is basically acute inflammation of the salivary glands. The interventions, of course, if it comes from you having decreased production of saliva, your interventions are going to be hydration, application of warm compresses, massages of the gland, and use of a saliva substitute, and that type of thing to treat that problem. Um, Also, as a result, xerostomia, which is spelled xerostomia, is basically results in a person having just very dry mouth over a long period of time. That's what they call that. Um, when a person is going through some type of radiation, there's very little that you can do at that time to alleviate that. So you just have to really focus in on frequent sips of water and frequent mouth care, especially before meals, or the most effective interventions that a person can pretty much do. And also, they do have what they call saliva substitutes for 2 to 4 hours at a time. And salivary gland tumors, and they're usually the rarest among oral tumors. Initially, malignant tumors usually present as slow growing, painless masses, often associated with radiation of the head and neck areas, or salivary gland tumors. Um, you got to assess, you gonna assess the ability to wrinkle the brow, raise the eyebrows, squeeze the eyes shut, wrinkle nose, pucker lips, puff out cheeks, and grimace to see if they have this ability. And the treatment of choice would be radiation uh, and parotid ectomy. So that's basically the treatment. Next, we're going to discuss patients on Chapter 57, care of patients with esophageal problems. The objectives for this lecture is to collaborate with the healthcare team when caring with patients with esophageal health problems that may impair swallowing or limit nutrition. Uh, Teach the patient and family about lifestyle changes with GERD and hiatal hernias. Teach the patient and family about post-op operative care after esophageal surgery, provide psychosocial support to patients and their families through diagnosis and treatment of esophageal cancer, evaluate the impact of esophageal cancer on the patient's nutritional status, and including the risk for aspiration. You're going to perform focused assessments for patients with esophageal health problems, apply knowledge of pathophysiology to monitor for complications of esophageal surgical procedures, teach patients with GERD about drug therapy, plan community based care for patients diagnosed with esophageal cancer. The first disorder that we'll discuss of patient with esophageal problems is care of the patients with GERD or gastroesophageal reflux disease. It's the most common upper gastrointestinal disorder in the United States. It occurs as a result of the backflow of GI contents in the esophagus. Um, Reflux esophagitis characterized by acute symptoms of inflammation. Esophageal reflux occurs when gastric volume or intra-abdominal pressure is elevated or the sphincter tone of the lower esophageal sphincter is decreased or is inappropriately relaxed. I've seen that asked uh, um, about the when it occurs on the exam, so to know that um, about the gastric volume or intra-abdominal pressure is elevated, or to know that the sphincter tone of the lower esophageal sphincter is decreased or inappropriate relaxed would be a good thing to realize as it relates to GERD. Also, you need to know that the pH of the acid secreted by the stomach ranges from 1.5 to 2.0, where the pH of distal esophagus is normally neutral at 6.0 to 7.0. So, you need to know about what the pH range are. The clinical manifestation is when a person usually has dyspepsia, and that's when they have like a substernal burning sensation, and what that lasts is usually anywhere between 20 minutes to 2 hours. Um, they usually have regurgitation, flatulence, those type of problems like that. Um, um, they might have hypersalivation, um, and they may have dysphagia, which is difficulties swallowing, and odinophagia, which is painful swallowing. Um, and that's a result of the neuron of the esophagus due to stricture or inflammation. Also, sometimes people have like chest pain and vomiting and belching and bloating, nausea, and that type of thing as it relates to them having this. Um, the way to basically diagnose GERD would be through the 24-hour ambulatory pH monitoring, um, or they could do an EGD, and usually that's useful in diagnosing reflux esophagitis. Um, Esophageal manometry, which is basically to see how the food moves, or like the motility of the food. Those are the ways to diagnose. So mainly they use non-surgical management, which includes a lot of times nutrition therapy, where they'll encourage individuals to eat like 4 to 6 small meals per day. And the types of things that they would like for you to limit would be like maybe your chocolate, alcohol, fatty foods, caffeine, mainly carbonated drinks and spicy drinks, anything acidic, and believe it or not, peppermint doesn't do well for people with that. GERD. Patient education is really designed for because GERD is like mostly a really um, chronic disorder. A lot of times they requires ongoing management. So it's like more than just, I'm going to do this for now and then it's going to go away. You have to do a lifestyle change. A lot of times what they encourage is people to elevate the head of the bed for sleep about 6 inches. So you want to sleep in left lateral decubitus position. Mm. Stop smoking and have an alcohol consumption. Reduce your weight. Wear non-binding clothing. Refrain from lifting heavy objects and straining or working in a bent over posture. So you got to make sure you have good ergonomics. Um, those are the non-surgical management. As far as like s- any type of drug therapy that is related to um, lower the lower esophageal sphincter pressure and cause reflux. Antacids elevate the level of the gastric context and LES pressure. Therefore, you're not gonna give uh, for like long term use. They'll use it like quickly, but not like for that's what you're just gonna be managed on. Um, Usually, what they use is for long term management is histamine receptor antagonists, and what they do is they decrease acid production. And the type of things that you would use that do that or consider that would be like the Pepsids and the Zantacs. Um, Protein pump inhibitors when you're using would be the Acifex and the Protonix and the Nexiums. Um, and these are usually effective for long acting inhibition of gastric acid secretion. So that's when the person has really severe GERD. They would use things like the Protonix and the Nexium and the Acifex. Then they have what they call protokinetic drugs, which are used to increase excuse me, gastric emptying and improve lower esophageal sphincter pressure and esophageal um, peristalsis. Okay. Other treatments is endoscopic therapies. Some of the endoscopic therapies that they would try to use um, would be the Strata procedure, and this is where the physician applies radio frequency energy through the endoscope using needles, and the RF energy decreases vagus nerve activity, and this as a result reduces the discomfort that the person is experiencing when they have GERD. Um, then they have what they call the gastroplication procedure, and that's when the physician actually goes in and tightens up the lower esophageal sphincter through the endoscope, and they suture it. And then they have what they call the laparoscopic Nissen fundoplication, which they call the LNF, and it's minimally invasive. And is the gold standard. So this is what they do the most for surgical management. Um, So, and prior to that, they are encouraged to continue following their basic anti-reflux regimen of antacids. And as a result, also the nutritional therapy, because of the rate of recurrence, is high. Okay, next we're going to discuss the hiatal hernia. The hiatal hernia is the protrusion of the stomach through the esophageal hiatus of the diaphragm into the chest. There are various types of hernias. You have the sliding hernia, and this is the most common, occurring when esophagogastric junction and a portion of the fundus of the stomach slide upward through the esophageal hiatus into the thorax. Then you have what they call the rolling hernia, which where the fundus rolls into the thorax beside the esophagus. Um, you have a risk of volvulus obstruction and strangulation, which are very high. Um, Here is a diagram which basically shows a comparison of where you have like the normal stomach, and then it's showing you a herniated portion of the stomach in a sliding hiatal hernia, and then the rolling hiatal hernia where it's like really, really visible for you to have a herniated portion. So if you want to take a look at that, that'll give you an idea of what you're dealing with. Okay, so for hiatal hernia, you're going to do an assessment. Okay, when you are performing the assessment, you need to ask the patient if he or she has any type of heartburn, regurgitation, any back workflow of food in the throat, which is regurgitation, pain, dysphagia, um, difficulty swallowing, excessive belching. You're going to assess the general physical appearance and nutritional status of the person. And you're going to see whether or not they have any breathlessness, um, and worsening symptoms after eating or when the person is in the recumbent position. You're going to teach the patient non surgical management and most important role of nursing when a person has uh, um, hernia is patient teaching. They're going to use probably some type of drug therapy, which would include antacids of some sort, um, and some sort of histamine receptor antagonist. They're going to do nutrition therapy, which will consist of uh, avoid eating like late evening, avoid foods that are associated with reflux. Um, and also, you do possibly want to discuss with a person something about weight reduction as well. Um, and also, you're going to make sure that they elevate the head of the bed 6 inches for sleep, remain upright for several hours after they've eaten, and avoid straining and vigorous exercise, and avoid non binding uh, clothing. Surgical management. Um, like this is all like repeat stuff of what I told you um earlier. I mean, like nothing is changing. What I'm saying is earlier I told you about the losing weight, quitting smoking, the operative procedure, that Nissen fundoplication. Um, we also told you about the respiratory care and deep breathing exercises, by using the incentive spirometer. Um, you might have a nasal gastric tube and might need to perform nasal gastric tube basic management, nutritional care for complications of surgery. Basically would include what they call gas bloat syndrome. And what that means is that just them having that swallowing of the air. Um, Achalasia is a rare, very rare esophageal motility disorder that results from loss of nerve impulses to the smooth muscle of the esophagus, characterized by chronic and progressive dysphagia. Over time, peristaltic failure plus muscle spasm can produce a massively dilated esophagus, which slows how the food passes. Um, the primary symptoms of achalasia is dysphagia and regurgitation of solids, liquids, or of both. Um, Basically, as far as drug therapy is concerned, you would have the use of calcium channel blockers, nitrates, and you would direct, sometimes inject some type of botulism toxin into the lower esophageal muscle. Um, Semi-soft foods and warm foods, arching the back while swallowing. You want to avoid restrictive clothing, and you want to eat 4 to 6 small meals a day. So as you can see, you guys, most of the management basically is the same for a lot of these disease processes. Um, um, then the next one you have is esophageal dilation, and that's the passage of progressively lower sizes of esophageal bougies using polyurethane balloons or possible catheter. Um, and what they do is they use metal like little stents, and what that does is that keeps the esophagus open for a longer duration. The complications of this procedure would be bleeding, signs of perforation, chest and shoulder pain, elevated temperature, and subcutaneous emphysema and hemoptysis, which is, spitting up blood. Um, Another procedure is esophagomyotomy. What that basically includes is a surgical procedure which is for the achalasia that we discussed earlier, and it's done to facilitate the passage of the food. Um, Usually they do it laparoscopically, and it's for long-term refractory achalasia only. And the surgeon may attempt excising the affected portion of the esophagus with or without replacement of a segment of the colon or jejunal. So they're basically going in there, taking out the portion that they think is the problem. Um, then you have a list of what they call esophageal tumors. Um, and of course, like anything, esophageal tumors can be either benign or malignant. The two primary risk factors for a person developing an esophageal tumor would be tobacco use and heavy alcohol use. Usually, when a person has Barrett's esophagus, is ultimately usually malignant. The clinical manifestations include dysphagia, odynophagia, regurgitation, vomiting, foul breath, chronic hiccups, pulmonary complications, chronic cough, and of course, hoarseness. That is the signs. So I suspect you would know that. Um, it usually grows really rapid because there's a lack of serosal layer. Um, also, there is some genetic considerations, uh, and they said that usually when a person is more prone, it's related to them having mutations um, uh, in the tumor suppressor genes. There usually is a history um, of risk factors and culture backgrounds, um, age, and gender issues. When usually esophageal cancer tends to um, um, occur most often in middle-aged and older adults, and it tends to occur more in black males, although the exact cause for racial differences is usually not known. White males are more predisposed to esophageal adenocarcinoma. So you want to ask the patient about consumption of smoked and pickled foods, changes in appetite, changes in taste or weight loss. Um, Cancer of the esophagus is a silent tumor and its early stages with a few observable signs. By the time the tumor causes symptoms, it usually has spread real extensively. So it's like a real rapid spreading cancer, and by the time a person knows that's what's going on, um, it has really spread. So, doing the physical assessment, you want to look for the same types of clinical manifestations that usually occur when you're trying to diagnose any of these disease processes. You want to look at dysphagia, odynophagia, regurgitation, vomiting, whether or not the person has halitosis or chronic hiccups. Um, Usually, a person has increased, anxiety, and that's usually around meal times because meal times usually are not a good time for them. So you may see some extensive weight loss. In order to really assess this, you need to do. You could do a BA, a barium swallow, esophageal ultrasound, and as well a EGD in order to um, diagnose it. Non-surgical management. We got to talk about the positioning up after meals. A person being on semi-soft foods or thickened liquid. You want to look at the swallowing therapy. Um, Another form of non-surgical management would possibly be swallow therapy, chemotherapy, radiation, a combination of chemo and radiation, um, photodynamic therapy where they try to go and destroy just the cancer cells, and then like we talked about earlier, but with the esophageal dilation. As far as the surgical management, and they may also do this in conjunction with the non-surgical management. You'll often find people they'll get esophagectomy, which is really the removal of all or part of the esophagus. And then they can also get esophageal gastrotomy, which is the removal of part of the esophagus and proximal stomach. Um, and then they can do like a minimally invasive esophagectomy. So it just kind of depends on what the extent and how far or how much, if at all, it has passed, whether or not a person has, problems. Um, so basically, right here is just a picture of the surgery, how it would occur. um, when you have somebody and you're dealing with their post-operative care, the highest priority is the respiratory care. The respiratory care, and then secondly would be the cardiovascular care. Um, Usually because of hypotension during surgery may sometimes occur because of blood loss or and then so you but at the same time you want to monitor for fluid volume overload. So you're going to assess for edema, crackles, increased jugular venous pressure, and then based on what type of wound they have afterwards, you want to do wound management. You want to prevent dehiscence and provide support during turning and coughing. And then, of course, you want to do whatever you can to prevent wound infections. So they may have drains. You do whatever you need to do. Prior to them having surgery, a person may have to nutritionally get strong up to 2 to 3 weeks or 4 weeks prior to the uh, surgery. So, as far as their post-operative care, um, you want to manage, they nasogastric tube. You're going to place intra-op to decompress stomach to prevent tension of the suture line. Um, do not irrigate or reposition unless ordered. Drainage bloody, and sometimes it might even be greenish yellow. The nutritional management, you need to initiate feeds through the J tube. Patient placed in upright position. You're always going to assess the swallowing. And also, they're going to eat 6 to 8 small meals per day. So that's basically what they have to look forward to post surgery. Community based care. Um, of course, they're going to have community based care where they're going to um, be dealing with community health post op once they get home. Um, Health teaching, hand washing, keep wound free of infection. You're going to provide them nutritional support. You want to elevate the head of the bed after meals. Sometimes they have healthcare resources like transportation, support groups, etc., um, to assist them with whatever they're going through. Uh, the next time, esophageal diverticula is what they call sacs resulting from the herniation of esophageal mucosa and submucosa into the surrounding tissue. Zinker's diverticulum is the most common of esophageal diverticula, and the clinical manifestations, just like I told you for most things, you guys, is dysphagia, regurgitation, nocturnal cough, and halitosis. They suffer from diet therapy for size and frequency of meals. So you want to make sure that they have small meals, of course, like with everything, and you're gonna make sure that they see the dietitian. Surgical management, of course, would be for you to remove the diverticula. Because there's a lot of different ways that I wanted you to talk about. Postoperatively, of course, the patient is NPO if they have surgery. Sometimes they may have a nasogastric. You want to make sure they receive IV fluids for hydration, and you want to provide pain relief measurements and monitor for any type of complications, like for instance, if they're bleeding or anything like that. Okay, and then last of the conditions would be the esophageal trauma, which could come from any type of blunt injuries, chemical burns, surgery, or endoscopy, or stress of protracted vomiting. So a person that could be vomiting all the time will get into that type of predicament. You will have chemical injury. Um, is usually a result of accidental or intentional ingestion of caustic substances. The damage to the mouth and esophagus is rapid, usually, and it's usually very, very, very severe. Um, and Usually, like if a person, believe it or not, if they ingest some type of alkaline burning material, it can cause deeper, more penetrating injuries, and it can also like really perforate through the full esophagus. So you need to really take notes. Usually, ingestion of any type of alkaline material would burn deeper or more penetrating than acid material. Nothing is administered by mouth, um, um, and usually they give a broad spectrum of any type of antibiotics. Also, the surgical management, it depends. It may be like a resection need to be done, and it basically depends on how severe and what type of esophageal trauma is to be noted. Okay, chapter 58 is discussing of care of patients with stomach disorders. We'll discuss people. Your learning objectives will be to describe the importance of collaboration, develop a teaching plan for patients about cats as it results to these disorder, identify the need for end of life care for patients with gastric cancer, um, um, know about assessment and etiologies of chronic gastritis, identify risk factors for gastritis, um, compare and contrast the difference between a gastric and a duodenal ulcer. We're going to talk about PUD, which is peptic ulcer disease, describe the purpose and adverse effects, discuss about the GI bleeding, gastric cancer, gastric lavage, and also gastric surgery as it relates. The first disease process that we're going to discuss is gastritis, which is mainly just the inflammation of the gastric mucosa. Um, you will have what they call acute gastritis, which was related to, the description of that is the early pathologic manifestation. Um, and then you'll have what they call chronic gastritis, which is appears as a patchy, diffuse, or spread out inflammation. Um, you can't diagnose these two, the acute and the chronic, based on length of time. It's also got to do with clinical symptoms as well. As disease progresses, for instance, with chronic gastritis, the walls and linings of the stomach may even become thin and they may atrophy. So, as a result, you have three different types. You have type A gastritis. Type A gastritis is described as non-erosive. Chronic gastritis refers to an inflammation of the glands as well as the fundus and body of the stomach. You have a type B gastritis, which usually affects the glands of the antrum but may involve the entire stomach. Um, in atrophic gastritis, the chronic gastritis has diffuse inflammation and destruction of deeply located glands and it accompanying the condition. So those are the definitions of those particular. Then you have Helicobacter pylori and E. coli can also cause. So if you got like um, either H. pylori or E. coli, they can also contribute to a person having gastritis. Um, so, some of the okay, we're going to discuss the clinical manifestations of gastritis. Um, Usually, people have abdominal tenderness, which could be from mild to severe. The patient may report some type of epigastric discomfort, anorexia, cramping, nausea, and vomiting, as well as bloating. You want to assess for abdominal tenderness. Um, Hematoemesis, which is really when they basically vomit blood, melena, which is traces of blood in the stool. Also, you want to discuss whether or not they're using any type of aspirin or NSAIDs, which may result in dyspepsia, which is heartburn. A person can have gastritis related to food poisoning caused by endotoxins, um, and the vomiting might occur, about 5 hours or so within them ingesting whatever they do. So, these are some of the signs and symptoms that you would look mainly when a person has an acute um, gastritis. Gastritis. Usually, when a person has chronic gastritis, it don't really tend to have a lot of outwardly symptoms unless it's ulceration occurs. Uh, they may report having nausea and vomiting or upper abdominal discomfort and some periodic epigastric pain. Um, Usually, when a person has like an acute gastritis, a lot of times it is associated with H. pylori, where a lot of times a person or it's either associated with them having H. pylori or them having using or E. coli or salmonella or something like that. Um, Usually, you can break like chronic gastritis down, and it's usually resulted to some type of local, like irritation over a period of time, or somebody having some type of disease order like a Crohn's disease or something like that. And usually, yeah, that's what um, it relates to. Um, Usually, people use what they call non surgical management for primary treatment when it first shows itself, identification and elimination of causative factors. So, whatever you're doing, which may be possibly contributing to you having that disease process, usually you're told to change it. Um, Usually, people use some type of drug therapy, um, like they'll have some type of antacid, uh, like magnesium hydroxide, Malox, or that type of thing. Some type of H2 antagonist. We went over that earlier, like a Zantac or a Pepsid. Um, they have anti secretory agents which inhibits you producing, like more acid or whatever in your stomach. Vitamin B12, and then whatever you need to do too, like maybe treat the H. pylori infection. Other therapies that they use would be like, of course, the diet therapy. And you'll listen, if you listen to me, you'll see where it's like everything keeps repeating itself over and over again. So you want to limit the intake of spicy foods, tea, coffee, cola, and chocolate, mustard, paprika, pepper, and of course the tobacco and the alcohol. And then you want to decrease the amount of stress as much as possible. Okay. Surgical management. If it's like a chronic and it's related to some type of disease process, like I was telling you earlier about the Crohn's and that type of thing, um, there could possibly be a surgical management um, where they take out certain portions of um, the stomach. They have partial gastrectomy, vagotomies, where it's or even a total gastrectomy can possibly be done. And down here at the bottom, and when you want, if you have the time and you want to read about various surgeries and that type of thing, you can look it up and you can read about like the Bioroth 1 and Bioroth 2 and procedures, because sometimes you'll see them throw that up on the test. Peptic ulcer disease is a mucosal lesion of the stomach or duodenum caused when gastric mucosal defenses become impaired and no longer protect the epithelium from the effect of acid and pepsin. So you have like various types of ulcers. You have the gastric, duodenal, and stress ulcers. Um, and like I said, they're caused by acid and pepsin and H. pylori infections. And they play an important part of people getting these ulcers. Okay, so here is just basically showing you how they look or how they develop. So they have various types. They have the duodenal ulcers. Most duodenal ulcers occur in the first portion of the duodenum, and duodenal ulcers present as deep, sharp, demarcated lesions that penetrate through the mucosa and submucosa into the muscularis propria. Oh my goodness! So these are like really kind of bad ulcers. Um, then you have like the stress ulcers and the acute gastric mucosa lesions occurring after an acute medical crisis or trauma. So that's like the difference, and they're associated with like head injury, major surgery, burns, respiratory failure, shock, and sepsis. Um, some of the names are like a Cushing's or Curling's ulcer, and basically you'll just have the bleeding, and you have to just try to work on whatever the source or the reason for the trauma is to prevent that from happening. Um, Complications of uh, ulcers would be Clinical manifestations is epigastric tenderness, usually located at the midline between the umbilicus and the xiphoid process. Also, I've seen that type of question before about ulcers. Dyspepsia, and like usually a person say it's a short burning or gnawing pain, and a sensation of abdominal pressure or fullness or hunger. So it can be like real kind of difficult to just from somebody telling you that that's what it is. Because a person may have acute or chronic pain, and one of the primary purposes for employing drug therapy is to eliminate or reduce the pain. So usually people don't usually use analgesics or like generally a pain medication to uh, to treat like when a person has a peptic ulcer disease. Ulcer drug regimen itself promotes relief of pain by eradicating the H. pylori and promoting healing of the gastric mucosa. So, whatever the treatment is to treat somebody with the H. pylori, you know how they have you on the series of the antibiotics, and then you might have like the Mylanta. I mean, they got like all the little different treatment regimen, three different things, together. Together, those and clearing up that is what the mainstay treatment is. Okay, and I just talked about that. I said provide pain relief, eradicate H. pylori, and heal ulcerations, and hopefully live a lifestyle so that you won't need it anymore. Okay, and then like the H. pylori treatment, because I think I kind of hopped over myself because I was talking so fast. Um, they usually do the Flagyl. They usually do the amoxicillin, and then they usually do something like a Zantac or something like that, and they have to take it over a real long period of time in order to treat the H. pylori. Um, Hyposecretory drugs, and which reduce gastric acid secretion, and those include the H2 receptor antagonists and the proton pump inhibitors, which we discussed earlier in the lecture. Um, some examples would be like the PPIs or protein pump inhibitors would be like the Prilosec, Prevacid, Acifex, the Nexium, Protonix. I know y'all have seen them and probably know them from pharmacology. The difference, the H2 receptor antagonist drugs are drugs that block histamine stimulated gastric secretion. They may be used for indigestion and heartburn, and they block the action of the H2 receptors. Um, Basically, the most common are like the Zantac and Pepsid and Axid. The prostaglandin analogs medicine are those agents which reduce gastric acid secretion and enhance gastric mucosal resistance to tissue injury. Those will be Cytotec. Um, and one of the adverse effects of this medicine would be uterine contraction. And then, of course, you do have your antacids, which um, buffer the gastric acid, but usually those are not like long term relief. The most widely used preparations are, of course, aluminum hydroxide and Mylanta, Malox, that type of, such as those type of things. For optimal effect, take about 2 hours after meals. And also always keep in mind that sometimes antacids, they can often interact with certain drugs and interfere with their effectiveness. And then the lab type of medicine, which you'll see that'll be real popular, is usually the carafate, which is um they provide like a protective coat at the base of the peptic ulcer, and it binds with bile acids and pepsins, and what it does by binding to these substances, it reduces injury from the substances. And the main side effect of that medicine would, of course, be like the constipation. Okay, nutrition therapy. You would have to talk to patients, and we've discussed this over again about reducing the amount of acid in their diet being more bland, uh, avoiding bedtime snacks, giving yourself a chance to digest, and avoiding alcohol and tobacco. The use of complementary and alternative therapies, of course, to reduce the stress. Sometimes people do things like yoga, and then they know that there are certain herbs that are thought to heal inflamed tissue and increase blood flow. Um, and other substances that people can use, which may include zinc or vitamin C or A or essential fatty acids and those type of things that people use. Of course, there's always a potential for gastrointestinal bleeding. Interventions would include monitoring and early recognition of complications, critical to the successful management of PUD, preventing and or managing bleeding, perforation and gastric outlet obstruction, and possible surgical treatment. Um, also, make sure that you monitor, because especially sometimes people are bleeding or vomiting and stuff. It's real important for you to monitor their vital signs and make sure that you're aware of any type of hypovolemia, and monitor serum electrolytes because they may be using it. Um, there may be a may have to insert two large bore peripheral IV catheters to replace both fluids and blood loss. Also, you're gonna volume replace, and it needs to be restored. And that's if a person gets that bad, or they come in and they're hypovolemic. Blood products may be ordered to expand volume and correct their CBC. And orthostatic hypotension is common, so, when a person has hypovolemia. And we talked about the Zollinger Ellison syndrome earlier in the lecture, so I won't be repeating that. Oh, but I could. Let me finish. Let me just go on and tell you just quickly. Um, is manifested by upper GI tract ulceration, increased gastric acid secretion, and the presence of a non-beta cell islet tumor of the pancreas called a gastrinoma. So, a lot of times where patients may complain of peptic ulcer disease symptoms and may have diarrhea and or steatorrhea, which I already talked to y'all about the fatty stools and whatnot. Interventions would be, the aim of the therapy is to suppress the acid. So you're going to use your choice drugs like your Prevacid, Prilosec, Zantac, and then if all of that, and they, of course, everybody always wants to go, they're not going to go invasive first, then you're going to do like the vagotomy or the pyloroplasty, or something like that, or be performed. That's always the last choice. Um, Then, lastly, we can talk about the gastric carcinoma, which means basically a person has cancer of the stomach. Infection with Helicobacterial pylori is the large risk factor for gastric cancer because it carries the cytotoxin associated with the antigen A gene. Clinical manifestations of that is asymptomatic, but indigestion and abdominal discomfort are the most common symptoms. Signs of distant metastasis include um, okay, so with the gastric carcinoma, oh, let me go back. We already talked about the manifestations, which are usually abdominal tenderness or discomfort, and indigestion, which is really they don't show up. They be asymptomatic earlier. Um, they have signs of distant metastasis, which includes okay, so like gastric signs of distant metastasis may include Virchow's nodes, Sister Mary Joseph nodes, Bloomer's Shelf, and Krukenberg's tumor. And like basically, I'm going to discuss these and tell you what they are. But physical examination may provide clues, to diagnose gastric cancer. And the presence of, like, when a person has, for instance, anemia, occult blood in the stool, weight loss may suggest a malignancy. Um, a mid, like if they got like a mid epigastric palpable mass or nodular liver, they may be helpful in localizing the process to the abdomen. The patient may appear completely healthy on physical exam. Additional findings may include abdominal mass, liver metastasis, gastric distension, weight loss, supraclavicular adenopathy, which basically is um, and so what they consider virtual child's nodes would be what they consider the supraclavicular adenopathy. Um, then Sister Mary Joseph nodes, which is the umbilical metastasis. Uh, Bloomer's shelf, which is a rectal mass, and then Krukenberg's tumor or syndrome, which they consider enlarged ovary. Also, they have like uh, all types of other little different ways where they put stuff together, like Trousseau's syndrome, which is where a person has phlebitis and it's like migratory, like all over. They might have uh, keratosis and freckles. So they have like a lot of little different little signs and symptoms that they tend to put together, which where they'll say that a person may have some type of gastric carcinoma. Of course, you can do a combination of chemotherapy and radiation therapy. And usually it's limited because of the fact that they said that it's often widely disseminated. Um, so usually what they do is surgical management and preoperative care is similar to that provided by general anesthesia and any type of abdominal surgery. And this may include subtotal and or total gastrectomy. Um, and all these post-operative complications a person can go through anything when they're doing abdominal some type of abdominal treatment, pneumonia, anastomotic. So wherever they anastomose um, the areas when they remove the stomach, you could have a leak there, a hemorrhage, reflux aspiration, wound infection. So I mean, paralytic ileus. I mean, it can go on and on and on of the type of complications that a person could possibly have as a result of them having It's really kind of wild. But like what I was telling y'all, even about the dumping syndrome, when I was talking about a person removing a gallbladder, um, um, it's real common when you start messing with the intestines or gastric, or anything with your GI system. And basically, that's the end of the lecture. If you have any questions, feel free to contact me or Miss Scott. Take care.